Okay,
Right.
thank you, Angaraj.
Yeah, thanks, Elena. Dr. Srirajaskanthan is a consultant and clinical lead for gastroenterology at King's College Hospital in London, and reader in gastroenterology at King's College. He's the head of King's Health Partners ENETS Center for Excellence NET Service. He runs a research program in NETS mainly focused on epidemiology, nutrition, biomarkers, and optimizing clinical outcomes. He's a member of the ENETS advisory board and carcinoid heart disease task force. More than that, Raj and I have been collaborating, can't remember, for quite a few years now, and he's a good friend. And over to you, Raj.
Well, thank you, Angaraj. Thank you for that introduction. I thought I'd talk on two areas of kind of interest to me. One was about epidemiology and some of the work we've been doing on that regarding kind of neuroendocrine neoplasms, and then looking also at the differences in survival, and also something which I think in practice we're seeing more of, which is second cancers occurring in patients who've been diagnosed with neuroendocrine tumors. There's a lot of our patients that come through the service have actually had previous cancers or go on to have other cancers whilst under our care. And then tying into that, one of the areas that was interesting was if we could kind of capture better patient outcome data to help with management and patient education. And that's been achieved in part through a mobile app, which we did as a trial. And it's just to kind of run through some of the findings from that and its potential roles in the future, really. So if we talk about incidence and prevalence, so, I mean, just to summarize, I think a lot of registries over the last European registries, either national registries or regional registries, have shown that there's an increasing incidence in neuroendocrine neoplasms. What we find interesting is that actually there's a global variation in the type of NETs. So in Asia, say China, Korea, Thailand, there's actually a very high incidence of, say, rectal NETs, whilst in UK, America, bronchial NETs are very common. So there's a variation in the type of NETs that are present. But in addition, we're seeing an increase in incidence as well. The issue we have when we're trying to capture this data is that different countries have different mechanisms of capturing kind of epidemiological data. The two which I'm focusing on in this talk will be some work we've done with the ANCRAS database, which is a UK database that captures all recorded, or 99% plus of recorded cancer diagnoses. And then also looking at comparisons with the SEER database, which is very well established for capturing US epidemiology data. However, it does have limitations in that it only covers about 17% of the population and insured patients predominantly. So, and then also I wanted to talk a bit about the consequence of that prevalence and how kind of NETs I don't think is anymore to be regarded as a rare disease. So I'm sure a lot of you have seen this slide. So James Yao initially published the first kind of big paper on epidemiology of neuroendocrine tumors in JCO back in 2008. And then this kind of follow-up paper from Dasari shows how there's been this increasing incidence of neuroendocrine tumors going at a much higher rate than other kind of malignant neoplasms. So in the top figure, you can see that the blue line suggests the incidence of all cancer neoplasms. And then the orange line shows the incidence of NETs, and you can see that rises continually kind of trending upwards. And this is seen on the lower figure, you can see that in the US data, this is seen in all types of NETs. So lung is the most common type, but there's been an increase in all types from lung through to pancreas. Now, when you start going into this in a bit more detail, one of the interesting findings, and this may be in part the cause of this rise, is actually a lot of the early stage disease and is actually what we class as localized disease is what's driving some of this increase. So the brown line you can see is talking about localized disease. This is non-metastatic disease. And I think some of this will be the tumors that are picked up either through screening colonoscopy procedures, such as the rectal NETs, or through gastric NETs as endoscopic imaging and quality improves, but also through kind of other screening modalities. Our threshold for using cross-sectional imaging like CT or MRI is reduced, and so therefore we're most likely picking up a lot more of these kind of incidental but also early stage tumors. The other thing that we're seeing is there's a higher amount of grade 1 tumors being picked up as well. So the question here is this because we're picking up a lot of the rectal and gastric nets, which maybe will be grade 1, or is it that these tumors are changing in their kind of biology? And that's a bit unclear. The metastatic disease is still on the increase. So I don't think there's that. I think there is a genuine increase in the incidence of these tumors. Beyond that of just the population aging, I think there may well be an increase, but we're not sure as to what's driving that, whether it's environmental or other factors. But I think some of the rise maybe is going to be multifactorial, but it's difficult to account for all of it. And so the reason this becomes quite relevant in terms of both healthcare resource utilization, but also kind of clinical service development, is that NETs have a very relatively indolent behavior compared to other aggressive cancer types. And so therefore the prevalence of the tumors is much higher. And it's estimated that in the US, there are over 170,000 patients living with a neuroendocrine tumor diagnosis. And when you look at the kind of prevalence data, you can see it's again been rising year on year in the Dasari paper. And this, I think we then need to start thinking about the impact in terms of health economics regarding patients with neuroendocrine tumors, and also kind of optimizing management and access to therapy. So if you have earlier tumors or earlier diagnosis at an earlier stage, you'll have less metastatic disease, and in theory, less healthcare utilization in the long term. And then there was a recent paper out of the team in Kentucky, and they looked at the kind of prevalence, and this chart, bar graph, is really quite important because it kind of highlights what I think we've suspected, which is actually, if you look at the prevalence of neuroendocrine tumors within the US population, they estimate it to actually be the most common type of GI cancer after colorectal. And I think that's a big shift. If you're thinking of NETs as still being a rare tumor type, I think this kind of graph shows actually it's no longer a rare tumor type. And we need to be thinking about it in a different way, as it being maybe an uncommon cancer, but with a very high prevalence and high healthcare utilization and things like that. So moving on to the NCRAS data. So this is work that we've done at King's and kind of nationally, and myself and John Ramage have been working on. And we had a PhD student called Ben White who's done an excellent job at working and collaborating with others in terms of pulling together this data with Public Health England. So the NCRAS database covers 99% of cancer diagnoses, and between 1995 and 2018, there were 63,949 patients diagnosed with NENS. We estimate the kind of prevalence of around 26,000 patients living with the condition at the moment. And this incidence has increased between 1995 to 2018 by 371%. And very similarly to the Dasari paper, our kind of reported incidence is around 9 per 100,000 population, with a mean age of diagnosis of 67. And what's interesting here is actually socioeconomic status doesn't differentiate between the incidence of these tumors. So they're occurring in both affluent and poorer people of backgrounds. So I think that's quite relevant as well. However, survival, interestingly, is very different to this. So if we look at the UK data, the England data, what you can see here is, again, very similar graphs to what we saw with the SEER database. So there's increasing trend in incidence, and again, lung being the most common, and then the colonic and cecal tumors being kind of least. But the graphs and the trend in the graphs are very similar to those seen with the SEER data set. What we can also extract from this, which you can't do with SEER, is actually look at the morphology, so both the neck and the NET components. And the reason this is relevant is what you see is actually, one is that patients with this under the age of 29 group, which is commonly the appendiceal NET, so the majority of those are neuroendocrine tumors. But as you go beyond kind of 30 onwards, there's an increasing incidence of neck neuroendocrine carcinoma. And I think this is obviously very important because the prognosis is much worse. But I think one of the things is we do need to be aware that they are occurring in patients well under the kind of classically foretold age in which cancer occurs, so they're 30 to 50 or 4 kind of age group. The other thing you can see on the chart on the right is that stage, again, as you get older, the number of patients presenting with early stage disease falls, and we get a higher and higher incidence of patients presenting with metastatic disease, almost reaching 45% by the 75 plus cohort, which I found was quite interesting data. So if we move from this on to survival, I've put side by side actually. So the table on the left is data from the SEER database in blue, and then the bar charts on the right are the England 5-year survival data from the NCRAS database. And what you can see here is appendix isn't recorded on the SEER data set, so that's why it's kind of always not all of it's recorded, so therefore it's difficult to make an assumption on median survival. But if you look at some of the others, they're actually very similar in terms of, for example, pancreas survival and small bowel survival percentages are similar to what we see in the UK data. I think the thing that confuses it obviously is that we've separated our NECs from our NET in the NCRAS data system, so therefore the survival may look a bit better for example, for the pancreas, but actually, if you include the cohort of pancreatic NECs, then it most likely equates out to being similar, kind of 50% 5-year survival. And then touching on this, if we look at survival by stage, site, and gender, so first of all, going on by stage, as you'd expect, stage 1 has a much better prognosis than stage 4, and there's clear separation on those graphs. I think it's really important, and again, one of the things we keep reiterating, especially to our referrers, is that a neuroendocrine tumor and a neuroendocrine carcinoma morphologically are very different, but also it's very important with the classification, because I think when patients are given an initial diagnosis, sometimes they're being told they've got a neuroendocrine tumor and it's quite indolent, when in actual fact they have a neuroendocrine carcinoma and it's quite aggressive. And I think terminology, it's important that we start being very clear about the terminology when we're discussing findings of patients, but also education going out to kind of referrers and making sure that the right terminology is used, because it also helps with understanding of disease behavior. As you can see, there is a separation in terms of survival, with better survival seen in females over males, so the blue line above the red line. And I'll go into this in a bit more detail, but basically this has been seen in a number of other solid cancers. And then finally by tumor site, which is, as we'd expect, with the colonic tumors predominantly being NEC type, they have quite a poor survival compared to some of the others, which are usually kind of predominantly NET subtype. One of the reassuring things seen in the SEER data sets from the Dasari paper was that there has been an improvement in survival over time. And they looked at different cohorts and categorized groups, and they sort of showed that even with metastatic disease and localized disease, there's been an improvement in survival over each time frame. And we did a similar thing with the NCRAS data, and again showed very similar findings, whereby with pancreas and small bowel, there's been a really marked improvement in survival over the last 2011 to 2018 cohort, and this is in part due to new therapies being available, but also I think better centralization of services, specialist MDTs, and kind of improved awareness of the condition as well. So survival in both the SEER and the England data is very similar. Finally, going on to kind of gender and survival. So as I've shown, and again seen in the SEER data set and many other studies, is that there is improved survival for females compared to males. And we did some work with Beth Russell and basically looking at this. And what we showed was that actually, when you take out on a multivariate analysis, what we found was actually the improved survival was seen both in lung, pancreatic, rectal, and stomach neuroendocrine neoplasms for females over males. And this increased survival was irrespective of stage. We did perform mediation analysis on this work, and basically what we showed was that I think a lot of females, well not a lot, a significant proportion of females do present with an earlier stage of disease. And so therefore this does confound some of the survival benefit. but there is still, I think, just a better prognosis for females than males in most subtypes of NET. And this is that data kind of in tabulated form. And as you can see, the ones highlighted in boxes are ones where we've shown clear improvement in survival for females over males in those 4 tumor types. And as I said, there's also evidence of improvement in both earlier stage of disease as well. The rationale for this or reason for this is unclear. I think there's some social factors into it, and there may well be some genetic and epigenetic differences. I think health-seeking behavior is different between males and females, and we've seen this with other solid organ cancers with delayed presentation in males over females. And so I think that is a aspect of this, but I think there are other factors we need to look into and examine further. There's just one slide on this. So whilst we know that incidence of neuroendocrine tumors doesn't depend on socioeconomic background, survival does. And what we've seen from the INCRAS data is actually as the more socially deprived and poor individuals are, the worse the outcomes. And we've sort of seen this on this data. So finally, the last area, which I think might be relevant, is looking at second cancers in NEN patients. So this, again, was done using the INCRAS database. And this was some work done by Frostel. And what we looked at was the number of patients diagnosed with a non-neuroendocrine tumor, either on the same date as a neuroendocrine tumor, which we class as being within 3 months of a NET diagnosis, a diagnosis of NENS before the diagnosis, a diagnosis of cancer before the diagnosis of NEN, for neuroendocrine neoplasm, and then finally a diagnosis of NEN, or a second cancer after diagnosis of neuroendocrine neoplasm. So the 3 groups. 75% of the patients diagnosed with second cancers were in the cohort who were diagnosed prior to their neuroendocrine tumor diagnosis. Okay, so that makes up the largest portion. And of those, breast, prostate, colon made up the majority of those cases. I think what you can see here is that in patients diagnosed with a second cancer after the diagnosis of neuroendocrine neoplasm, so this is the 25% of those second cancer patients, the most common ones seen were prostate, lung, breast, colon, and renal. And I think the reason this is important is obviously we do have screening programs for some of these conditions, and so it's really important that we highlight to our patients that just because we're doing surveillance imaging for them regarding their neuroendocrine tumor, they should still participate in any kind of national screening or other screening programs that are available to them. And we highlight that to our patients when we see them in clinic. One of the difficulties with this is working out whether or not the incidence of these tumors is higher than the background or kind of population just as standard incidence rates. And so we did look at this within this group of patients. And we did see that there were especially a number of cancers which were occurring at a higher incidence than that seen in the background population. And this is shown in this table. So thyroid, bladder were commonly, and lung were commonly being seen more in the NET cohort above the background population. And when you separate it by gender, what you see here is that in both groups, lung is more common, as is colon and renal cancer. However, in females, in addition to that, and thyroid, in addition to that, in females, we saw a higher incidence of stomach cancer as well, and bladder. And again, it's unclear as to why that's been identified. So we had to think about what, and these are just potential suggested, not kind of recommended for any guidelines or anything else, but we just thought one of the things we noticed in our cohorts was that there wasn't always a clear incidence as to the type of NET that you had a diagnosis and what second cancer you might be more likely to develop. But what we thought would be reasonable is, again, to consider FIT or colon screening for patients with GI NETs, and to screen for things like lung, thyroid, and renal, where we feel there's a higher risk of cancer, to consider X-rays or examining the thyroid every few years. These are just provisional ideas. They're not like they've not been kind of endorsed by any kind of national bodies. So moving on from this, I just briefly will talk a bit about some work we've done on kind of digital health. So about 5 years ago, we thought it'd be interesting to develop kind of mobile app technology in terms of healthcare. So there'd been development a number of cancer-related healthcare apps. However, a lot of them were kind of generic apps, not tailored to specific tumors. And also their role was a bit unclear as to whether or not they were just primarily for acting as an aid for patients as an educational tool, or whether it's for collecting PROMS data, and how their role could be developed in terms of regular patient management. And I thought it would be interesting, and we worked with NCUK and UKNet to kind of develop a bespoke mobile app which patients actually designed the content for in conjunction with clinicians, and then we used it to see whether or not there was an interest in utilizing this and whether it helped with both patients reporting their symptoms and outcomes, but also from a clinical perspective, whether we found it helpful to have this kind of data recorded. So its primary function was to offer all NET patients in England, and actually in England and Scotland, the free mobile app, which they can then act as a link to kind of online resources, so health education and tools to help with managing their condition, and then also provide ability for them to download their kind of health record and also collect kind of PROMS data and quality of life questionnaires as well. And the idea was to kind of monitor this longitudinally. Like I said, there were some other apps available, but a lot of them were generic for cancer utilization, and so therefore they were done without a lot of patient involvement, often done by IT firms rather than designed for patients. So when we spoke to patients, what they wanted to have included were ways of reporting their symptoms, a portal for linking into their clinical team, a link to online resources and other information like that. And so we developed a steering group of both patients and clinicians, and then also kind of ran patient forums for them to contribute into what they felt would be useful for the app. We ran an advisory board for clinicians to kind of contribute what they felt would be useful, and then we sourced an app developer to design the app, a company called Ampersand, and then we wanted to see whether there was an interest in this. And this is kind of a screenshot from the app, and these were some of the things it could collect. So, you could report daily symptoms like abdominal pain, fatigue, your mood, whether you're doing exercise. You could record your medications and also add into your clinical history as well. And then we linked in some kind of health-related questionnaires so they could collect data, like the GINET21, for example, and record that. And then those would be sent to their clinical team as well prior to their clinical appointment. And this was run over the last 3 years. And then from the clinical side, we could see which patients were using the app. We could communicate them from a messaging function. We can see what PROMs they'd submitted. So kind of it's a two-way interface. And like I said, we could message them if we wanted them to do any blood tests, or if we wanted to let them know something about appointments and things like that. The results from the study was actually quite a few patients did register to use the apps. There were 710 individual users. Because we didn't insist on all patients consented to use it, but we didn't insist on having minimal data recorded for us to utilize it. So therefore, as you can see, a lot of patients didn't record their gender, for example, or their type of primary tumor, for example, like that, or their age. And so therefore, a lot of the demographic data is unknown, but where we do have it, we can see there are quite a few users. We can see that there was a focus around London and utilization, but actually there were patients downloading and using the app throughout the country and in Scotland as well. And again, a lot of the patients that record primary site, but a lot was small bowel or pancreatic, gastric, GI nets, from what we could gather. And over 670 completed kind of quality of life questionnaires, on average 1 or 2 times during that time. And then this was what was really impressive, was actually over almost 32,000 recorded symptoms and tracked their symptoms. And on average, each user was recording about 140 plus symptoms. And you can see it kind of incrementing over the years. And so this showed that there was kind of, I think from a patient perspective, there was some value in recording these symptoms that allowed them to look back at how they were finding their condition and managing it. What we did see, and I think this is part of the whole role with healthcare utilization, is that if there isn't any feedback from the other side of the service, so for example, from the clinical side, the utilization of the app drops off. So we had a lot of people used it, one to 5 times, less using it beyond that, and then very few using it very frequently. And I think what was happening is that people were recording their symptoms, and if they found it helpful for themselves, they did. I think in terms of the problems data, if that wasn't being then utilized or examined by the clinical team, which we found was happening, then actually I think patients then less frequently utilize the app. And so I think kind of what we learned from this was that I think there is a patient engagement with the app was very good. I think it acted as a good interface for collecting kind of symptom data and problems data. And if we could integrate it into kind of a routine clinical care, then I think that would be very good. I think a lot of the problems with this is that all of these items are kind of independent and bespoke to kind of healthcare technology. So the problem you have is that you need one app for your kind of Epic patient portal, you'll need one for this and one for that. They don't integrate. I think if in the future, I think if we can kind of merge these into one, then that would be very helpful. So I'm just coming up to a close. So basically, in summary, I think there's a global rise in incidence of neuroendocrine tumors. It's multifactorial. I don't think it's just due to imaging or increased use of kind of endoscopy investigations. I think social demographic status doesn't impact on incidence, but does impact on survival. And the age of onset is broad, and so we need to educate people to think about investigating patients even under the kind of classical age, like in the UK of under 60. It's very hard to be treated on a two-way pathway unless they're very kind of overt symptoms. So we need to have a lower threshold for considering this diagnosis. There's a very high prevalence of neuroendocrine tumors due to the good survival. And so therefore we need to think about kind of modeling this and healthcare impact. And this is where I think things like digital health could be really important, because I think if we can, a lot of our patients, especially who've got cured disease who are under surveillance, a lot of them may well be under almost lifelong surveillance. And so if we can integrate kind of digital health into their care, then they may well have a fallback to just be managed. A lot of their care can be managed remotely if they don't have any ongoing symptoms. And we may be able to kind of use digital technology for both education, awareness, and kind of reducing clinic attendances and healthcare resources as well. And the problems data, I think, would be very important. There's a lot of the time when we see people in care, we don't get a true grasp of how they've been over the preceding 3 to 6 months, whilst if we had this problems data, which is often completed 6 weeks before appointment, it would help then direct the consultation that you have and may well change kind of approaches to ongoing management as well. So thank you, and I'd like to thank all the people that collaborated with us over this research over the last 10 years.
Thanks, Raj. This is really very interesting, and providing more information about the incidents and where we are at this with the NENS, as well as, well, I mean, most exciting was about the app that this is really, I think, helpful for patients, I guess. Questions from anyone to Raj?
Thank you so much, Raj. That was an excellent presentation, and really emphasized, that there's still so much work to be done. And actually, I thought of a question for Poe, my fellow basic science researcher, on this during the talk, because you brought up potential differences in gender and sex rates of neuroendocrine tumors. Poe, have you ever experienced differences in growing tumors, say xenografts, in male versus female mice? Because we have. And I was curious if that was something that you noticed. The male mice that we implant the xenografts into, the tumors grow a little bit quicker than the female mice.
Yeah, yes, I do. And we've had that observation, like I think last year. And thank you, Raj, for publishing those data, because I was always thinking that, oh wow, well they're growing like smaller in the female. So it's really nice to see that you see survival differences and females like they survive longer, right? Like
So, I mean, there's good
it's that
data that actually in females, for example, if you look at small bowel nets, development of mesenteric fibrosis and mesenteric masses is actually less in the premenopausal group than it is in the postmenopausal group. And I think the Dutch group, Walter de Herder's group, have published on this, and actually we've got data on this that I think there appears to be almost a protective effect from estrogen and progesterone, and we know that we've seen that in kind of HER receptors and ER and PR receptors in NETs, and there's some impact on that on kind of both tumor proliferation and progression as well.
yeah,
This
thank you.
Yeah, this is interesting. Again, to follow up on that, I was just about to ask the question ERPR, but you all already have answered. And related to this, in pancreatic adenocarcinomas, we are speaking. My student is writing a thesis where we also find obviously adenocarcinoma, the difference in male versus female, and we did some for PO as well. We did some work in mice, and even we see in some of the not only epithelial cells but cancers of fibroblasts, there are quite some difference, and also the immune system acting very differently in these mice. But it's very interesting to see that in neuroendocrine tumors, but it's not only seems to be in pancreatic, but also in the other cancers, which is quite interesting. Denny?
Yeah, thanks. I just had a quick question about, and maybe Dr. Del Rivera will be able to help add some to this as well, but in the data sets, you talked a lot about the stages 1 through 4. And just anecdotally, I'm involved in about 4 different patient support groups here on the West Coast of the US. And probably 95% of the people are all stage 4 with distant metastatic disease. So we don't really talk about stage at all. We talk about grade and well differentiated or poorly differentiated. And so I was surprised to see the numbers that you're tracking in some of the data sets in stage 1, 2, and 3, and wondered if that was just the US experience, or at least the experience that I see anecdotally in the support groups is something that's odd or different from globally.
One of the things we do see is that patient engagement in support groups is often also partly linked to stage. And a lot of the patients that have early stage disease, stage 1, 2, they often have a curative resection, go into the surveillance program, and they don't necessarily always even register or engage with the national charities. And so a lot of our support groups, a lot of our we hold an annual patient meeting, and I'd say 90% of the people that attend that have metastatic disease. The patients that have localized disease or no active treatment or not on any active treatment, they often don't necessarily engage in, some do, but the majority don't engage in those support groups. So I think that can lead to a very skewed view of how you see it. And also even in our clinic, a lot of the follow-up post-surgical ones may be followed up by surgeons. So our clinics will be 50, 60% patients with stage 4 disease. So you only see a fraction of what's, I think, like you said, it's to do with the environment and the groups that you're working with as well.
Yeah, that's really interesting. I think that's important for the patients to know that as well, that that isn't talked about here.
Yeah.
So thank you.
I add a comment, may I make a comment based on? Yeah, sorry. So I think one of the questions that you're asking is about, it seems that based on your data, you see earlier stage neuroendocrine tumors compared to the experience, the patient experience and the different support groups of what we see. But that said, why we're seeing more earlier neuroendocrine tumors is because we're doing more procedures, we're doing more colonoscopy, more endoscopy than what it was 10 years ago. So incidentally, we're finding those neuroendocrine tumors by doing those procedures. That said, a lot of our patients, as you may know, they're diagnosed later, and sometimes they are mistaken because of irritable bowel syndrome, of other GI issues that not necessarily are neuroendocrine tumors. And then we have the non-functional tumors, the ones that doesn't secrete hormones, that by the time they're diagnosed, they are on the advanced stages or metastatic settings. So I think I agree that we need to have better screening tools and to be able to diagnose earlier. But that said, the reasons why, we see, more earlier stage neuroendocrine tumors is because we're doing more invasive procedures, like I say, colonoscopy, endoscopy, that we didn't do before. I don't know if that answered the question, Mr. Organ.
Yes, thank you.
Just wanted to echo what you said, Denny, that I think that I agree with. I mean, that fits my anecdotal experience as well in support groups, that the people who, and I actually kind of wanted to point that out to the presenter, that in fact, so let me start from the beginning. Yeah, I think that those who are most involved tend to be those who are most in need of involvement. And so those might be newly diagnosed, actively undergoing treatment, or sort of in a stage of maintenance, but where it's never going to go away. And so some people drop out. Basically, you have a survivor bias in the groups, would be my hypothesis, and fits my anecdotal experience. And then likewise on those apps, which I think are really interesting. And I'd like to know, I don't have any specific questions. I just kind of generally like to know more about it. But most specifically, you notice the declining use. And I would think, I think you raised a good point that without, basically, what I heard from you is like, without actually creating community in some sense, without connectivity, without the interaction, the loop being closed and the people on the other side responding and reacting, then you didn't continue to generate the interest. In addition to that, as people's problems go away, they will, be disinterested perhaps in continuing to engage unless they really identify with it. And so I think that we noticed that I represent a group that supports and represents the MEN1 and MEN2 populations. And so with let's take MEN1. You might go through surveillance and then you have, say, a parathyroid surgery, and then you're just done for 5 years. So in that interim 5 years, we think that folks are less interested in being involved. And I think that you'd find that reflected in an app as well, even if we were watching for symptoms. I think it depends on how vigilant folks are, where their set point is. But that's what I guess. I guess I wanted to highlight that and see if you had any responses or thoughts on inter-disease interactions.
No, I'd agree with you. And I think, so I think the feedback we got from patients was the app was useful for its educational purposes because you could get links to other centers and therefore it acted like as a hub, which otherwise people just go on Google and, you can get, whilst if you say to someone, this is actually, verified by us and kind of, that these sources you'll go to will be, accurate. So that's useful. And there's an online library and a lot of information about diagnosis and tests and what to expect and things like that. So that was useful, and videos as well. I think you're 100% right. If you don't get feedback from recording symptoms, and you almost, unless you're doing it for your own personal record of time, you won't keep engaging with it. And the issue we had was actually the patients were engaging. The issue was actually from the clinical side. So we had all these centers where patients were basically filling stuff in, but then they weren't getting any feedback at their consults that someone had actually looked at it. And so then you think, well, actually, this took 20 minutes of my time. If no one's looking at it, why would I do it? And conversely, if you're not going to use it as your portal for messaging because you have to do it for another hospital IT system, then it's duplication of work, so then people don't use it. So I think what my learning from it was that I think if you integrated it into core kind of digital healthcare and made it seamless, then I think people would migrate towards using it more. But it has to be a two-way relationship between the healthcare clinician and the provider and the patient. It can't just be requesting data and asking to communicate something, but not then interacting with what you get back. And conversely, if someone sends an email through that service, but no one responds to it, well, then it's pretty pointless, isn't it? So it has to be you know, and that's why it needs to integrate into the platform that you're using. Now, I think, so that was my main take home from it, was that actually I think it could work, but I think it involves a lot of careful thought, planning and structure and buy-in on both sides of that equation. And then it could actually be really useful. But it may well be a good option, especially, you know, like that Young 2 group. For those 5 years, you don't necessarily need to be, say, doing anything active. But if they had a digital interaction and a way they could just email in and say, I've got an issue, rather than having just annual appointments where they might not necessarily need, it's just literally touching base, they could give them that avenue, and you then save 5 years worth of appointments. So if you see what I mean, there are a number of ways you can improve efficiency and without losing patients to follow up, without making people feel that they're not being supported. And that those are the kind of things that I think we need to look at integrating. But it needs to be done in a thoughtful manner and kind of with complete buy-in on all sides.
Well, as a follow-up to that, kind of one of my, what's the role of patient organizations there? Because I think that that's a really important role that, you know, that's what something that we can do is we can really try to, I mean, I know that's my goal, is to generate a sense of community and to have and sustain a community. And maybe, you know, I think that data could be really valuable. I mean, obviously it would be very valuable. And so how do we keep getting it and capture it? I'd love to see that kind of like constant stream of patient reported outcomes. I don't have, you know, I don't, there's a whole bunch of barriers to that, but that's, you know, I would love to see that happen. And so I see a role for, possibly a role for community or for community organizations, basically, to do that. What role how could you see that playing out?
I mean, I think a lot of again, it's very similar to what Denny was saying, is that there are a cohort of really avid patient kind of involvement. So there's this, and we know this, whenever you do a Twitter survey for a cohort of patients, you know, you send it from your charity, there'll always be this X cohort of patients that will respond, you know, and you've got your core group, but they're only about 10% of the entire population with the condition, right? So you're missing 90%, and the key is how do you engage in that group, the wider group? And I think some of them don't necessarily want to necessarily engage, but there might be some that would be willing to, but you just need to work out a method to access that. But we see that here, and it's similar to what you described. It's those 3 groups like you described earlier that that I think, you know, very similar in the UK as well.
So following up on that, you know, what would be the next steps, Raj, you know, with this data?
Well, I think, I mean, for me, it was kind of showing, so the NCRAS data, I think I'd like to look at health economics. I'd like to kind of model and look into that in a bit more detail, especially when you look at ENETS guidelines and kind of, you know, for example, for the bronchial neck, you're almost talking about kind of lifelong surveillance. And actually, there's good data from Simran Singh's kind of group. And actually, if you look at the Scandinavian data, they don't discharge patients, right? They will have it lifelong surveillance going on 10, 20 years, even after a locally resected small bowel net, because they showed that 50% of recurrences will occur in 5 years, another 25% will occur at 10, and there'll be another group that will occur beyond that. And so I think, you know, we're looking at needing to model healthcare around that, and ENETS have suggested bronchial nets get, you know, as atypical with no almost, you know, lifelong surveillance. So I think we need to understand the health impact. We have to show how earlier diagnosis can model that impact, especially if you get people before they have metastatic disease. And then we need to think more about, you know, this mention about the biomarkers. If we could avoid imaging and use a blood-based biomarker, you know, there's a lot of interest in the NET test, modeling's NET test and things originally, but there needs to be some way of us being able to kind of accurately capture that imaging. That would be a great kind of option. So those are kind of areas. I think from the epidemiology side, it would be, there's always more to be done with that, you know, understanding the variations in survival and outcomes and drilling down into that, and whether the incidence is purely investigations or whether there is more to it, which I think there is. I think there is a increasing metastatic disease, but it isn't due to increased age. So I think there are environmental factors. and we're looking at geographical locations of primaries and things. So I think there's stuff there, there's stuff on health economics. And in the mobile lab, it was an interest of mine, and I think it could work, but I think it's a big project. So it most certainly needs to be taken on at a national level to kind of integrate it into being a requirement for, PROM data requirement for orthopedic surgeries like standard, right? So if we can incorporate it into cancer care, it might well be that we then start collecting good data, especially after certain interventions and therapy. You get really good real world data. If you had people collecting after PRT, their quality of life data remotely for 2, 3, 4 years, you get some fantastic data. And it can be done really easily, but it's just having that buy-in.
And just quick, a couple of points, maybe we can follow up some other time is, one thing is currently with the ChatGPT era, I think this data would also provide mining some of those things with language models, more thinking, more sophisticated stuff. The second thing, currently we are working on developing a patient digital twin, basically using the data as kind of an I think for COVID with people who cannot visit the hospital, I think it was a major problem. So similarly, if you can use this data to actually in a way kind of predict or project things for patients so that they could follow up and things like that. I think I know it's kind of a long shot, probably depending on how the data and quality of data and all those things, but it looks like a very interesting opportunity that you've been creating, and this is exciting. Any other questions from others?
I have a question.
Sure.
Thank you. This is actually really timely. I been looking forward to this talk, and then also recent. So I've been thinking about this. Some recent conversations with patients, and a rare disease. Are NETs rare? Now, I guess I have a question. I pose this question to the group. When and how would we start to differentiate between, say, a lung net as a truly different disease versus a small bowel net? And so maybe small bowel nets and pancreatic nets are clustered together, right? And they aren't rare, but lung nets still are. Why are they all nets? I mean, and then you in your talk, you didn't address, say, pheochromocytoma. So thinking about MEN2 patients that we might be interacting with, that's a net that wasn't included. Is it rare? And I don't know, I don't know how much it matters. I think it matters because people, they're like, I don't have anybody to talk to about this, or I don't know anybody who has had my experience, and that's important to them to kind of find their place. When something's rare or not, I think that can make a difference. So going back, the actual question is, what about segmenting nets into more than one group and say, okay, well, small bowel nets, well, it turns out they aren't actually that rare. They're the second most common GI malignancy. But lung nets, those are actually still pretty rare when you look at all cancers. And I don't know that that's the case. That's the kind of like the question I'm trying to ask. Are they rare? Would you segment them apart?
Again, it's country-based in a way. So, for example, in the UK and in America, lung nets are the most common subtype of nets, right? So therefore, you would say it's the most common type, but it only makes up 1 to 2% of lung cancers. So it's a fraction of the lung cancer cohort, but it's the most common type of the net cohort. So it becomes very confusing. Whilst in Asia, so kind of, Korea, 90% of them are rectal nets, right? And they don't get many lung, and they don't get them many small bowel comparatively, or they don't publish that much on it. It's always difficult to know, because you can only go on what people have in their registries, and you don't know what the registries are, how comprehensive they are. And so that also skews some of what we know, because we can't know what we don't record, if you see what I mean. I think if we want to improve the profile of nets in terms of people's awareness of it, then I think the risk with segmenting them is that you make all of them very rare. So I think you're better off pulling them together. And then I do, one of my things is that the pheos, the paragangliomas, and those, they get a really raw deal because they're so rare. They never get included in many of the trials. It's a real problem actually, and it's really difficult. And yet, you know, the cohort that get them are young. You want to have more options available for them, you know, and so that is yeah. So I think for that group do, you know, they do need more. I think they're better off being included within the cohort of NETs, and we should do. But unfortunately, a lot of the trials, when they're designed and a lot of the other stuff, they don't include them, and then you end up in this situation where you have very limited therapeutic options for them.
That's really
Yeah.
helpful. Thanks.
Yeah, thank you. I think we are end of the meeting, and I mean, thanks, Raj, actually, for agreeing to give this talk in a short notice, and it's a really very interesting talk. And thanks, Selena, to you.
Thank you very much. I think we'll agree that was really, really interesting talk. Lots of discussion. I love it when we have lots of questions at the end. It's really great. So thank you once again, Raj. Really appreciated. And just to remind everyone that our next meeting will be on September the 28th. Lovely Poe is in charge of our next speaker. So details of that will be coming up soon. So thank you again, everyone, for attending. It's been a really great meeting. And Raj, thank you so much. It's great.
Right. Nice meeting you all.
Thank you very much. Thanks a lot, everyone. Thank you. Bye-bye.
Bye now.
Bye.